All right, so we'll get started. So, all of us go to MDT meetings. In MDT meetings, it's very common to see a case like this one. In this case, a surgeon from outside came to discuss the case at our cancer center. So, 39-year-old female, she got rectal bleeding, and she was found to have rectal cancer, and tumor biopsies showed moderately differentiated colon cancer, MLH1 and PMS deficient. The patient has strong family history of colon cancer. So in this case, actually, there are three things. Patient is young, 39. She has family history. And then the most striking is this, that the tumor stained positive for MLH1 and PMS2. Now, this is the most important thing that the whole presentation is on. So the surgeon really did not have background about this. What does this mean? So we told him, wait a minute, this is very important. So, like in the DNA, there is pairs. So C cytosine goes with guanine and A with T. That's the normal DNA structure, right? Now, in the DNA synthesis, if there is any mismatch where the G will not go with the C, there is a structure of 4 enzymes, MSH2, MSH6, MLH1, PMS2. So our patient is deficient in the last two, the red and the green. What does that mean? So look at this here. Those 4 structures, they build together, and by doing so, they help in the repair. Actually, that's good then. So you see here, this is A with C. It should be G with C, right? So this is a mismatch. So the structure of the 4 enzymes will correct it. And now the DNA is corrected GC, and it keeps going. Now in this one, there is one missing. So this structure machine will not work. So AC, when the DNA is sensitized, it stays as AC to the end. So now we have a deficient DNA, and this we will call it MSI, meaning like microsatellite instability. Now this is DNA with mutation, and it was recognized a few years back with the most important article in this one, 2015, in the New England Journal of Medicine, that if you have a mismatch repair abnormality, so MSI high tumor, then if you give immunotherapy, it works very well. So this is the idea of this landmark article. And in this article, you see here actually pretty much everything red here, it has no mismatch repair. Now here we have 2 colors. The light blue, those are cases of colorectal cancer. The dark blue is other cancer. So in all those, you see like when they were treated with pembrolizumab immunotherapy, the tumor marker, instead of keep going up, it went down. And then here you see like all those cases, there is response. So this is not necessarily colon cancer, but the blue ones are colon cancer, colorectal cancer. Now also, if you put it for an MSI low, so in this case, it doesn't work, as you can see here. And this is here, like it translated to big difference in the curves, even for overall survival. In this study, most cases were found to have partial response and not complete response or stable disease. But later on, we'll show some results even better. And this is like a busy slide about side effects, but basically, it's the normal side effects seen with immunotherapy. So this study showed that mismatch repair status predicted clinical benefit of immune checkpoint blockage with pembrolizumab. And this is why actually in this deficient cells or mismatch repair deficient cells, MMR deficient, T cells can attack them and kill them. Now, back to our case. So how common you can see a case of rectal cancer with MMR deficiency? 5 to 10%. So it's not like every case. That's why we were excited when we saw the case with the mismatch repair. Now, those cases, the majority of rectal cancer is really Lynch syndrome. So those cases, it's hereditary, like it is in their, it's in their genes. So we call it germ cell mutation. So look here, the red, this rectal cancer, most of the cases that are mismatch repair, they have Lynch syndrome. They have abnormality inherited. Now, if you look at colon cancer, not it's the minority, 33%. Now, back to our case. So our case, actually, we did a PET scan as part of the workup. So we put the PET scan here. You see the rectal cancer here. And you see some lymph nodes involved around it. So it is, we marked some of them. So it's N2A disease. So we are dealing with a stage 3B rectal cancer. This case actually from November, or roughly November last year. But now if you look at most recent NCCN guidelines for MMR deficient MSI high, checkpoint inhibitors are recommended as a start. So either dostarlimab, nivolumab, or pembrolizumab. Now, for us, we were pretty excited about dostarlimab in this case. Why? Because there was a big news that came in the ASCO meeting 2022. In this ASCO meeting, they presented 14 cases that had dostarlimab, and all of them had a complete response, where eventually they didn't even need radiotherapy, chemotherapy, or surgery. So most likely cured. And this was like a big, huge news. And if you look at the study design, the study actually, they said, okay, we'll give dostarlimab first, 500 milligram every 3 weeks, 9 cycles. That's around 6 months, okay? And with close follow-up. Then if it doesn't work, then the patient can still get chemo, radio, and surgery as how we do it for a long time. Now, this is description of the patients. There are males, females, etc. They're matched. And this is here the germline mutation status. Now, this is here the result. Look at that. Complete response. Digital rectal exam, complete response. How many? 14 cases, all of them. So all patients ended up with just you give immunotherapy. But again, like what we said, you have to select this 5% cases that they are mismatch repair deficient. And this MMR actually is done by immunostain. So now we are really requiring the pathologist to do immunostain after they say adenocarcinoma, colon, or rectum, to do the immunostain for the 4 mismatch repair genes. Side effects really very limited. Look at the last curve, grade 3 and 4, 0. So it's well tolerated. And in this study, there was a complete response in 14 patients where they were avoided chemo, surgery, radio. Again, this is like for a surgeon, colorectal surgeon, it's really, you don't want to get any surgery, It's really like for the surgeon we worked with, I mean, you're going to take us out of business, at least for those cases. So that's what happened. Well, we started with the dostarlimab immunotherapy. Now, from the first cycle, the patient stopped having bleeding. She opened up, she became better. But the surgeon was very concerned, very concerned. He was saying, oh, she's still constipated, the colon is still narrow. Okay, if she progresses, it is your responsibility. If she perforates, your responsibility. I said, okay. Eventually, what we did, we had to do, like at 4 months, a PET scan to clarify where we are, actually. And you see here, the lymph nodes, no more FDG positive. The tumor, very little activity, and the colon is open. Despite all that, actually, I think there is culture issue. The surgeon wouldn't be convinced 100%, and we had to go through MDT. We tried to push our side. Eventually, he decided that really he wants to take her to surgery with agreement with the patient. So she got 5 days of radiotherapy, and she went to surgery. And it's laparoscopic, so this is the tumor he took out. And the result, YPT1, N0, So there is big post-treatment effect. All lymph nodes are negative, few just cancer cells still left in mucin pools. But again, we were not able to run the 6 months course. So this is a lesson for everybody. That's why it's like culture issue that we had to kind of discuss the case, show cases, to say, yes, this is a treatment that works. And now I have 3 minutes left, so in 3 minutes what I'll do, I'll tell you that pembrolizumab in microsatellite unstable MSI-SI, it works in advanced colorectal cancer. This is also proven, and it's in the New England Journal. And let me just show you the curves. So if the patient gets pembrolizumab, the progression-free survival is better. Now, I think this is just the general idea that immunotherapy is better. I don't think that I have the time to discuss the fine specifics, but I'll just show a few things. I think they may be helpful, which is here, okay? So if the patient has KRAS or NRAS, you see it's on the right side. So maybe if you have a patient, now this study is for locally advanced cases. So if I have a patient KRAS, NRAS, I'm gonna consider cetuximab first or panitumumab. So I'll consider antibody. And side effect-wise, it's well known. And in this study, complete response 17%, partial response 50%, and progression-free survival was pretty good. So in conclusion, pembrolizumab led to significantly longer progression-free survival than chemotherapy when received as first line for MSI-high, which is deficient MMR, metastatic colorectal cancer, with fewer treatment side effects. And thank you.